Welcome back and thank you so much for staying with us. The country, that is Kenya, is celebrating the World Immunization Week that began on the 26th of April 2023 under the theme, The Big Catch-Up. It is important that we all take action and encourage friends, family and community members to catch up on any missed vaccinations. And to have that conversation is none other than the CS for Health, the Cabinet Secretary for Health, that is Susan Nakhumincha. Thank you so much for joining us on KTN News and for making time for us.
Thank you, Maringa, and congratulations for getting my name right.
It was quite some practice.
And I'm happy to be here and pleased to inform Kenyans on what we are doing about immunization.
Brilliant. Thank you so much. It's your first time here as well, right?
Oh, yes. I haven't been here before. I've been to other media houses, but there's always a first time.
We're glad to have you as well.
Yeah.
I mean, top of mind, we're having, you come at a time, of course, the country is going through the occurrences we've seen at the coast. You know, the deaths reported, the Shakahola massacre. I mean, I'd like to pick your mind on, your reaction to whatever we are seeing going on down there.
Marina, thank you and for highlighting that. Let me begin first of all by giving my condolences to the families affected by the dubious so-called pastor. Maringa, I am a Christian, and once in a while I do fast as a Christian. For the record, I'm a very staunch Catholic. And we've just come from a season of fasting during Easter period. And similarly, our Muslim brothers brothers and sisters have also come out of a season of fasting. But it's clear that even during this fasting, there are those that are exempted from fasting. For example, the sick, pregnant mothers, the children, and some who may have their immunity compromised, they are exempted from fasting. That shows that this fasting is not for everyone. And number two, for us, the Catholics, as we fast during this Easter period, you're told to deny yourself not just food, but things that you really like, luxury, And the Muslims as well, they deny themselves and they now give that money to a good cause. I'm not sure about these ones that the so-called, I do not want to call him pastor, but that Mr. Mackenzie, I'm not so sure of his teachings. But you can see clearly that it was misleading, and many people have been affected by that thing. In fact, I watched today when the news, the journalists were saying that they are affected. People who are now involved in the exercise of exhuming bodies. It's not a natural occurrence that you are exhuming bodies in those large numbers. So it is torturing mentally. And even this morning, while in cabinet, we discussed largely about it. And we agreed that this is time that Kenya must take bold steps in terms of some of these practices that are being perpetrated by some of these people. So very regrettable, very regrettable. But I want to ask Kenyans to be on the lookout, that should you see something that looks unusual, should you see something that looks not out of the normal, it is just good to report, to have the issue checked. Because I believe there are many people who could now be suffering in silence, but because this has been profiled and awareness has been created from this Mackenzie guy, I believe there are so many other people who are going to come up and tell us what could be happening in some of these churches.
For those perhaps who may be salvaged, I mean, if someone would come across them, what would be the ideal scenario if they approached or, called in the health services, the hospitals to come and assist them?
Not even an ideal. We are already together with my people from my ministry. We've already been a part of the team that has been at the coast in terms of exhuming, so that then they can give nutritional guidance to those who have already been starving and now they have been rescued. They can give nutritional guidance in what they need to be given just to bring them back, but as well to give some guiding and counseling, because that process in itself is traumatizing. So people need to debrief. I have counselors from my ministry who are already down at the coast working together with the rest of the rescue team. As you heard today on TV, my colleague Kindiki, we have put together a multi-agency team that is tackling this issue from all fronts. That is a security issue, it is a health issue, it's a social protection issue. You heard my colleague also, Florence Bore, speak about it. So it's a multi-agency kind of team that is taking care of the people affected all around.
So now to the topic of the day, the World Immunization Week. Kenya is, of course, joining the rest of the world in marking this. And we're coming at the backdrop of the most recent high calling for immunization or, vaccine, that was the COVID-19 pandemic. Talk to us about the importance, or rather the risk of not getting immunized in the first place.
Vaccination is very important because it protects people from getting disease or illness. So obviously, it goes without saying that if you are not to illnesses, and for example, especially children, if they are not vaccinated, they don't get their childhood vaccination, that child, they'll grow with a lot of illnesses. You could also get disabled. For example, we know people who are disabled because of polio. Yeah. So if you don't get vaccinated against it, you could get disabled. And the worst is, it could be fatal, that people can die. But again, need to say that I need to highlight that those who are not vaccinated pose a risk to the larger society. If you take, for example, COVID, if one did not get a vaccination and they were mingling with other people, it was high chances that they would be able to pass this to the other person. Another thing is like measles, is a communicable disease that if you don't, if you are not vaccinated, you go down with it, then you pose a risk to the people around you.
Talking about COVID, is the vaccination drive still ongoing?
Yes, it is ongoing because we still need to build our herd immunity. We have sufficient doses of COVID vaccines within the country. And now what we are doing as a ministry is that we have integrated COVID into the regular vaccination so that then people are able to get it at all other facilities.
Okay, and is it introduced at childhood as well? I mean, you see the routine that comes, in the vaccination of a child. Was COVID introduced, or was that conversation held on how to perhaps just
the integration of COVID, it's not being given to children. It's being given to teenagers and adults.
So where can one ordinarily get vaccination services across the country?
Maringa, the network, the health facility network of this country is quite diverse. We have so many health facilities, but to be precise, in public facilities and also private, more than 8,000 facilities, one can get vaccination. And if you're just to divide that probably roughly by the number of counties, then you know that you have over 150 places or facilities where one can get a vaccination, where you have the vaccines will be available, the health worker to provide them will be available, and there's at least the infrastructure to be able to keep and store vaccines in those places.
And when you come across the issues that you saw in Shakahola, perhaps perhaps immunization is one of the areas or steps that the kids, the ones who died, may have skipped due to the doctrines that were being taught. When one does not go through immunization, what would be perhaps the incentive to allow a mother or even a guardian, a caregiver, to take a child for a vaccination?
Let me not talk about incentive, but the mere fact that we have said if you don't get your child vaccinated or yourself, then you are at risk of getting illness. Illness right now, many people are struggling, and I'm sure even as we sit here, Maringa, most likely you are in a WhatsApp group of somebody who needs to be assisted in terms of to meet their medical bills. So if you don't get vaccinated, increase the chances of illnesses, it affects the family socio-economically. That the money that would have been put into useful use now goes into treatment of a sick person who just did not go through vaccination. And we are talking about prevention. And the Kenya Kwanza government is big, and we are saying we are shifting the way we are delivering healthcare from curative services to promotive and preventive. So vaccination is one of the ways of preventing illnesses. You talked about the facilities, the 8,000 available across the country. That's about 170 across the 47 counties. In going with the hashtag Afya Mashinani initiative that the Ministry of Health has been working with, how are you able then to reach those in far-flung counties, especially in ourselves as well? Under this devolution arrangement, we no longer talk about far-flung counties. Maringa, it will interest you to know that last month I was in Mandera County, and the people of Mandera told me, since devolution, I'm the first cabinet secretary for health to be in Mandera. And I did not go to Mandera for a show off. I went because of doing specific things. Like we launched the blood transfusion center, the satellite, and I was also able to listen to a team, a task force that the governor had put together to be able to revolutionize or rethink the healthcare of that country.
Yeah.
So under the devolution system, we can no longer talk about far-flung. But that is not to say that there are not challenges. We have a few challenges here and there in terms of infrastructure. So we collaborate with the county governments to ensure that they deliver healthcare and vaccines to those ASAL places. But we also have partners that we work with. And especially in immunization, we work with UNICEF, we work with the PATH, we work with WHO, amidst others. You know, those ones, they already have a very strong community network. So we work with them in terms of being able to provide immunization in those kind of areas, the ASALs specifically.
And when you talk about immunization, of course, it is administered by a health official, so a health personnel. So when you talk about reaching those counties, does that mean with personnel as well? You know, increasing personnel to those areas will be able to assist in these services for those counties? Of
course, yes. You know, not anybody can administer a vaccine.
Absolutely.
It has to be a health worker.
Very true.
So, and this is where collaboration comes in. That at the national level, we provide guidelines on immunization, but the actual service delivery is done by a health worker who in most cases is an employee of the county government. Similarly, the partners that I have talked about, most of them are even supporting health workers who are able to reach in those kind of areas to deliver that. But most importantly, in terms of moving forward on how we are delivering healthcare, Maringa, the Kenya Kwanza government has prioritized community health promoters. Previously, they were called community health workers or volunteers. But now we are re-engineering and calling them community health promoters. We are recruiting an army of almost 100,000. To be precise, by yesterday when I was checking my figures, we had close to 97,070 community health promoters across the country. These are people that we are going to use to be able to take statistics of households. And immunization is going to be part of what the things that they'll be asking for. The other thing that they'll be looking at when they get to household that is really such a menace right now is alcoholism and drug abuse. Those are some of the things that we expect that this army of community health promoters is going to be able to leverage on and bring them up for national decision making.
COVID-19, you know, revered the vaccination activities and the efforts, especially not only for the citizens, but also for the ministry, because it took a toll coming at a time that it was perhaps unexpected, you know, and the modalities that were involved. And this situation was made worse, and there is zero-dose children. Talk to us about the commitment to reach the zero-dose children.
Thank you. I think we do not need to belabor about the challenges that came with COVID. One is that global supply chains were closed. Even the vaccines reaching this country, they came very late. And that is why you see coverage is low. Due to that closure, then many other services were affected. Many mothers did not get to take their children for vaccination in fear of COVID. So we lost quite some gap there. Number two is that children who get vaccines, like for example the HPV vaccine that is given in schools were closed. So those could not be reached. So now we have begun doing outreaches. We have an acceleration exercise whereby then campaigns and outreaches are done to be able to catch up. So far we have over 72% of the school-going girls who are supposed to be vaccinated with the HPV, they have already been vaccinated. So I think we are already making very good steps, because after the situation reopened after COVID, then we put in place mechanisms to be able to catch up on those that had lost their immunization. You're moving now from the children and those in the vulnerable, you know, in the society. Talk to us about the implementation of rotavirus, the HPV catch-up plans. How is that coming along? Yeah, exactly. The one I'm talking about, the HPV, you know, it is normally administered to school-going girls between the age of 10 and 14 years. So during that time when COVID was with us, schools were closed. So getting these girls to be able to give them the vaccine was not easy, because it meant people moving around. But remember, again, we were constrained of movement. There were lockdowns. So what we have done is that when schools reopened at the end of 2021, then we put in place mechanisms that then we accelerate these programs, that people actively go into schools, the health workers, to be able to provide this vaccination. Similarly, for rotavirus, there was a challenge, and it was actually a global challenge in terms of the manufacturing of rotavirus. virus. Now that it is available, we are also doing programs and outreaches, and especially through the assistance of our partners to be able to gain on what we lost during that time. Yeah.
Are you still, is the ministry still experiencing the stereotypes that came, with vaccinating the 10 to 14-year-olds, the girls in school? There was quite some stereotypes that you would quite filter to mention, but a lot was being said. Is that still happening?
Of course there was, but with the passage of time and the awareness that has been going on, and I really want to thank the health journalists across all the media houses. They have been doing a very good job, because we understand that for us to be able to capture this monster called cancer, prevention, early screening is key. Now, HPV specifically to take care of the cervical cancer is doing very well. And the awareness has been created. Even last week, you remember, was it this week? Together with the president, we launched the cyber knife treatment for cancer. That means that it has gone to the other level. But when we get a chance to put in prevention, which is the mantra of this Kenya Kwanza government in terms of delivering healthcare, that we focus on prevention and promotive. So we are happy with what is going on. We just need to upscale our awareness and creating awareness amongst the communities, amongst the societies, that it is okay for girls to get this vaccine at the age of 10 to 14 years. Because what you run to get into later on would be much more expensive in terms of management. So we'd rather have the vaccine.
Madam Waziri, you will agree that financing immunizations and vaccines is quite a tall order, and it involves a lot of expenses, especially for the government. And we've had not once, even during the pandemic, partners were involved. You've even mentioned earlier on about partners. Talk to us about the Gavi transition and ensuring a sustainable financing for vaccines and immunizations in the country.
True, as you have said, that Gavi is expected to transit in 2030, and that is mainly because as a country we were reclassified. Initially we were in third world, but right now we were as a country, which is a good thing, we were reclassified to middle level, and that is why Gavi, we know that it shall be transiting from 2030. As a country, and especially my ministry, we are making steps towards this. And the country so far, we do co-financing for Gavi vaccines. So the country so far, we have been able to put in 2.5 billion for financing of vaccines. But on the bigger scale, as I have said, the Kenya Kwanza government is redefining on how we deliver healthcare. So we are restructuring on how we finance healthcare in general, with a focus on preventive and promotive healthcare. We have structured our financing of healthcare in 3 levels. There's the primary level, which is going to be publicly financed. Then we have the secondary level that is going to be financed through a social health insurance scheme, which is around reforms and restructuring of NHIF. Then we are proposing a 3rd level of tertiary care, where then we have a critical fund that then takes care of those who have critical and chronic illnesses. So we are restructuring the whole space of healthcare financing, and I want to believe that it will bear fruits, because scientifically it has been proven that for every shilling that you put in preventive and promotive, you save 10 on treatment. So it is a worthwhile course in terms of refocusing and shifting the paradigm, having a paradigm shift on how we deliver healthcare.
I was, coming to that, how do we then move from relying so much on partners and, coming now to, sourcing and financing that from government? And when you look at it, is it a sustainable model? And perhaps how much of then partner input would you have if you go through the 3-tier type of financing that the government is seeking to adopt?
Maybe I need to explain to you a little bit about what we are doing in the long term, the Kenya Kwanza government.
Please.
One of, we are delivering universal health coverage. His Excellency the President has committed. My ministry is responsible for ensuring that we attain and achieve universal health coverage. In so doing, we have 4 main pillars under universal health coverage. We have the pillar of the health workforce, and you can see we are already injecting close to 100,000 community health promoters. That is part of the health workforce. We are also working around the issues to do with the other cadres of health workers, the doctors, the nurses, through and very soon you will see us launching the Kenya Health Human Resource Advisory Council. So that takes care of one of the pillars of UHC, that is the health workforce. The second pillar of UHC is use of technology, that we want to leverage on technology to be able to deliver healthcare, that we have end-to-end visibility in terms of how we manage health in this country. Yeah. And eventually we want to have every citizen of this country to be able to have their health information on their phone, and therefore move from one facility to the other to be taken care of without having to move files around and being asked a lot of questions. The third pillar of UHC is health commodity security. And I believe that is where your question now lies in terms of what are we doing in terms of sustainability. One of the things that as a ministry we are focusing on is local manufacturing. As you may be aware, as a government, we have Kenya Biovacs, which is responsible and has been tasked with the responsibility of ensuring that we manufacture vaccines inside this country, so that then we don't get to face the challenges that we faced like during COVID, and to build our own sustainability. But number two, we have public-private partnerships. I'm sure you must have seen in the news like about a month ago about Moderna that is coming to set up a manufacturing plant for mRNA technology of vaccines. Number three, you have had my colleague Moses Kuria talk about the whole space of being able to provide special economic zones where anyone who wants to do manufacturing, and we shall be giving special attention to those who want to do manufacturing, especially for medical commodities and supplies. And from the dispatch from Cabinet today, if you have had a chance to read, is that we are exempting interest to those that want to establish manufacturing plants for vaccines and for biopharmaceuticals in this country. So you can see clearly that we have a plan on how we want to ensure that then we are self-sustenance. But that notwithstanding, I really want to thank the partners that they have worked with this country all this time to the level that now we are thinking towards what is how we can be self-sustaining. And the fourth pillar is the health financing, which I've told you that we are engineering, we are restructuring on how we finance healthcare. And we want to bring everybody on board so that we have the public, the faith-based, and the private. Equally, we shall involve our donors so that we all come to the same table and speak about how do we then do this financing, which I've already told you about the 3 clusters that we would like to deliver it. Yeah. So
then that would mean the issue of lack of medicines is something that, in pharmacies is something that would be in the past. And have you noticed that perhaps, when you go through the counties, the health being a devolved function, if you could talk to us about the challenges that perhaps exist when collaboration and ensuring that health, the idea of universal healthcare and also providing healthcare for all is achieved in the counties as well, in line with immunization, whether there is available, immunization drugs for the children and everyone else that needs to be immunized.
Maringa, according to Schedule 4 of the Constitution, the roles and responsibilities are clear on what the county government needs to do and what the national government does. As the national government, we are supposed to provide policies, to provide the guidelines, to provide training and capacity building. While at the county, they are responsible for service delivery. If you look at immunization, it is a clear way of demonstrating how collaboration works well between the county government and the national government. Only yesterday, we launched an immunization policy. That was done by the national government. But who are we launching with? With the people who provide healthcare within the counties. In fact, a number of counties received awards in their exemplary performance on certain aspects of immunization. So as much as we are doing the policy for immunization at the national level, the counties, for example, provide the workers, provide the infrastructure, provide the logistics that is required for this immunization. So it is possible for the national government and the county government to work together collaboratively. But again, and most important, Mariga, is that we are looking at a Kenyan citizen as a wholesome citizen who requires a service. When you are sick, you don't choose whether you want to go to a county facility or a national facility. So we are re-engineering the whole health space so that jointly we can be able to deliver UHC, the national government and the county government, without clawing back on the benefits of devolution. It is very clear on what each level needs to do.
Perhaps, you know, as Wenda Waziri, it would be unfair to, especially the viewers, when we said you were coming, a question, you know, has plagued, I'm sure you may have seen on social media, on Twitter, regarding the, you know, paying of medical doctor interns paid in January for internship. And it would really be unfair because they have really asked, it's been boggling on social media, perhaps see on your account as well. And they're saying it's been 4 months without salaries. Would you speak to that, and how is that being addressed?
Maringa, I think for the number of times I have appeared on any TV station, that has been a question. And any time that I get to update anything on Twitter, that has been the question. Remember initially, just when I had assumed the office, the question was, when will you post interns? Didn't we post?
You posted.
We did, about 800 of them. And they're already within their facilities where they were posted, they're already providing work. Now, the other question is payment to interns. Onboarding of internship is a process that once you are posted, then you are expected to go to your facility report. Once you have reported to your facility, it confirms in writing that you have reported. You are supposed to bring back to the national government your documentation. Once you bring back your documentation, then you are given a personal number. Based on that personal number, then your payment is done what? Is processed. So we have a number who may have challenges because they have not provided the documentation that is required for generation of personal numbers for payment to be done. And I have asked my director of human resources to reach out because at times some may send and you know, in between the logistics and distribution of and movement of paperwork up and down, something gets lost or misplaced. So I don't want to say that we are challenge free, that we are very good at what we are doing. So there are those that have missed out because of that. But there are those again that were for because of budgetary allocation, which we have now received, and payments should start flowing. But there are those that we did post at the very last month. Those then will begin in June. So it is work in progress. And for those that went in January, for whatever reason that you are not getting your money, please check with the national government. Come and ensure that we have all your documents and you have your personal number generated for us to be able to make payments. Let them know that we do not, as a ministry, we don't generate personal numbers. They're generated by Public Service Commission. So we still, there's a process. But that notwithstanding, we have a long way to go in terms of being able to streamline our processes to be able to meet the needs of our health workforce. And one of the things that I have directed that we do is that we move digital. So that some of these things, they are captured.
Because like it sounds like a matter of process.
Yes, so that you are captured from, and I'm saying it will be so good if we get a health workforce management system where you are captured from the day you start your training. As a student, your details are captured, so that as you go through the motions that now you have finished your classwork, you're going for practicals, your details are with us already. You have finished, you need internship, your details are with us. You finished internship and maybe you're getting into employment, your details are with us. And that is something that this government is very clear about. Digitization and the digitalization agenda. I'm sure you've heard my colleague Owalo talking about the infrastructure that they want to lay, the digital superhighway, and we want, once those infrastructure are laid, then all ministries, we should be able to plug in and play in terms of IT, and it will resolve most of these issues that we are not getting right due to the manual system and the poor processes that we have.
So they will be guaranteed to be paid soon?
Of course, yes. They will be paid. You know, there's no way you can be given such a responsibility and not get what is due to you. They are supposed to be paid. So there could be a delay, but they will get paid.
Thank you. You know, as we end up the conversation, talk to us about your vision and, you know, what the life portends for you at the Ministry of Health, among the key issues you want to achieve, you know, during your tenure in the Ministry of Health, and what you envisage this country's health system to look like.
Marina, thank you very much. And one, I want to say that you may be aware, and if you are not, we are running with the hashtag of Afya Mashinani. This government is a bottom-up government, that it wants to take care of the people who are the bottom of the base.
Yeah.
And we are leveraging on the bottom-up economic transformation agenda. That whatever it is that we are doing, we must begin at the bottom, going upwards. Similarly, in delivering of UHC, we are focusing on mashinani, afya mashinani. That is where we have begun with community health promoters.
Yeah.
Every single community health promoter will be in charge of 100 households. What does that tell you? That as a ministry, we shall have the data of each and every household in this country. And the data that we shall have, we will of course know your bio. Of course, we will know in terms of if you have any health concerns within. We shall know if a family has a disabled child. And just recently we had a discussion with the Deputy President. We were in Nyeri talking about alcohol and drug abuse. We shall also be capturing that. What does that tell you? That once we have this data, then we can now plan from a point of information on how we deliver healthcare. But what we want to do is to also ensure that our systems are working from down. We are going to have things that are, we are going to have primary care networks. That once this these community health promoters identify an issue, you are referred to a level 2 facility.
Okay.
Once you're referred to a level 2 facility, you'll be seen there. If your issue needs referral, then they refer you to the next level of facility. We have developed an essential package that defines what is it that you should get at each and every facility that you get into. After the benefit package, Maringa, it will interest you to know that from next week, we are doing a gap analysis of all our facilities to know what is the gap in terms of equipment, what is the gap in terms of human resource, what is the gap in terms of infrastructure. Once we have identified this gap, then we do a reclassifications of levels of service. You know, we have facilities that by name, they are known to be level 4 facility. But if you go in and see the equipment, the workforce and all that, it could be a level 2.
Yeah.
We are going to have a reclassification of services. Once we have that and we know what is missing, Kenya Kwanza government has prioritized that we shall no longer concentrate on brick and mortar in terms of building, but we shall concentrate on equipping these facilities, that we equip them to be able to provide the level of service. And similarly, we have a plan on absorption of health workers so that then they are able to provide services at the different levels of service. Yeah. So in terms of what I want to be known of is the person who brought healthcare at the bottom. Because so far, it's curative in nature. You'll see somebody with a common cold walking to Kenyatta.
Okay.
It shouldn't be that way. If you have a common cold, you should be able to be taken care of at your nearest facility. But why are they ending up in Kenyatta? Is because this facility nearest to them, this level 2 facilities maybe has no medicine, maybe has no health worker. You see, that is why they end up. But I want by the end of my term as a cabinet secretary for health, everything we shall be at the bottom, that you shall get services from your nearest facility. And I want to encourage Kenyans that let's speak to these community health promoters that we have, because these are people that are trained. These are people that the government is kitting, and a kit is close to 50,000 Kenya shillings, one kit. And we are talking about how many community health promoters? Close to 100,000. That is an investment that the government has put into that kit, so then they are able to use it to pick out the issues within the community. Number 3, that the Kenya Kwanza government is co-financing these community health promoters on a matching basis with the county governments. So I want to speak to all Kenyans at large. Please, once these community health promoters come into your household, let us register ourselves. It is for our own benefit, because we want to improve on how we deliver healthcare in this country.
Do you not foresee a challenge, in the registration of, the community health workers, the promoters? When they go to households, there has been quite some stereotype and people having quite some resentment, especially the public healthcare facilities. What would be, perhaps, apart from just urging them to be able to register with them, because in terms of tangible results for a country that has not witnessed so much of, in terms of even lack of medicines in these facilities, apart from just telling Kenyans to register, what would be some of the incentives and the benefits to be able to just see that they are on board because you're helping the health promoters to register the Kenyans?
Now, one is that, it is said that it's only a fool who keeps doing the same thing, the same way, and expecting different results.
Okay.
We are shifting on how we want to deliver healthcare.
Okay.
For example, through the data that will be collected by these community health promoters. And that is why I'm encouraging people to ensure that they open their doors and they get registered by these community health promoters. We shall have accurate numbers. From the accurate numbers, we shall also be able to determine our disease burdens. What does that mean? That then we shall be able to accurately quantify and forecast for our medical supplies and needs.
Okay.
If we are able to do it accurately, then what that means is that we are able also to proceed with the other processes in terms of procurement of these medical supplies. But when we don't have accurate data, then it becomes very difficult to quantify and forecast. We may work on assumptions, and we do not want to work on assumptions. By the way, these community health promoters, we are giving them gadgets. As I said, this government is leveraging on technology. So when they come, they'll not come with paper. They'll come with a gadget, key in your data. Immediately they key in your data. At the Ministry of Health, we shall be able to have your data. Based on that data, we shall use it to make key decisions in healthcare in terms of how do we equip the facilities, how do we quantify the health needs of this country.
When should we expect to see them in the, deep in the interior villages as well?
Next month, which is a few days from today, those are 3 or 4 days.
Yes.
His Excellency the President should be able to commission them once we are at the tail end of finalizing training and acquiring the logistics regarding them. Once the President has commissioned them and launched them, they'll go straight into mashinani and they will start seeing registration happening.
What about research, regarding the cancer trends you've also seen? Would this be able to then inform how you conduct research and also equipping facilities such as Cambria and cancer?
Of course, yes. Remember, I have mentioned that we are doing a reassessment of facilities to identify the gaps.
Yes.
This will now form a basis. And remember, I have said that they'll be grouped into primary care networks.
Yes.
These primary care networks will have a governance system. The governance system shall involve the public, the faith-based, the private, and even partners in that space. So they are the people who will be discussing the health issues within that primary care network. So it is going to be easy, let me say, and it is going to be a planned way on how we deliver universal health coverage. Yes.
Indeed. Thank you so much, Madam Waziri. We've been speaking to the CS for Health, that is Susan Nakhumincha, here on KTN News. Thank you so much for making time for us. Quite ensuring that I get your name right.
Yes,
Nakhumincha.
and practice makes perfect.
Indeed.
So keep mentioning it.
Absolutely, we'll ensure, and we look forward to hosting you once again right here on KTN News.
Thank you very much. It was my pleasure.
Brilliant, and thank you so much for your tremendous feedback. My name is George Maringa. As always, stay safe and be kind to one another. I'll see you next time.